Okay, I'm going to go and we'll talk about the management of multiple myeloma. And the important thing in the management is the diagnosis and making a decision of when a patient has multiple myeloma that needs to be treated. And that's probably the most important decision. And the ones that come after that are usually much simpler. But this is a patient of mine who is a 56-year-old man, and he was found to have an elevated serum total protein during a physical exam for a life insurance. And that's actually a very common way in which patients present to us. Someone had a question of, why isn't a test for myeloma part of a routine physical? Well, it's not part of your, a total protein is part of your annual physical exam in most places. And so, sometimes it shows up in that way. And it turned out that the reason the protein was high in his blood was because he had a myeloma protein there that was an IgG kappa. And everything else was normal. And his x-rays were normal. He didn't have any bone lesions that we could see on a regular x-ray. And we did a bone marrow. He had 25% plasma cells, and there was a genetic abnormality, which were summarized there, says FISH 1114. It's chromosome 11 and chromosome 14. So he had some genetic characteristics of patients that have MGUS or smoldering or myeloma. Doesn't really tell us which one of those things it is. And so at that point, that's what we would have called smoldering multiple myeloma. But recently, we've changed the definition. This was about 3 years ago, and we've included more advanced imaging than just a regular X-ray. And you can see that over on the right. That's a PET-CT scan that identifies high level of activity in his femur, right there. You see? The yellow signal is abnormal, and that's a bone lesion with causing destruction. So in fact, this patient would now be called multiple myeloma, and whereas in the past we would have just observed him, now we would treat him. And that's where it's important that you need to have a careful assessment of all the information before the decision to treat is made. So when you do that, you need to really partner with your whole healthcare team, and there's so many things that go into that decision. With almost the same lab tests, you might treat one patient and not another when you take the whole patient into consideration, which is the age, other things they may have wrong with them, and how they're feeling, and also the patient's personal preference. How do they feel comfortable with living with disease which is controlled and not causing them problem, or do they feel that they want to eradicate it at all possible costs? Hopefully not all costs, but patients have different philosophies. And so there's no single one way to treat patients. And so just like that question that Dr. Krishnan had, we don't tell patients you have to have a stem cell transplant. We present the options to them, and they make the decision that's right for them together with their care team. And so what are we looking for? Why do we treat patients? Well, to induce the remission that we talked about earlier, basically that means get the disease under control. We like a high response rate. That because often when the disease responds, the patient will feel better. The pain will go away. Their anemia will improve. And so we like to see that happen as soon as possible. And when we do that, they get stronger and they feel better. Obviously, we'd like to have as few side effects as possible. And we want to prolong the survival, but at the same time, we want to make sure that we give the patients a good quality of life. So smoldering multiple myeloma. The current approach is that we don't offer treatment to those patients, and we monitor them closely, typically every 3 months. And if they have evidence of bone loss, we'd offer them drugs to strengthen their bones, something like Zometa or Iridia. But there are currently clinical studies ongoing for patients that we know have smoldering disease that's at high risk to progress, looking at early treatment for those patients to see if it offers them any benefit. And so if you're in that situation, you should talk about it with your doctor to see if you're interested in participating in one of those trials. Someone had a question that if you had smoldering multiple myeloma for 5 years and you haven't progressed, does that mean that you're in the clear, that you're less likely to progress? And the answer is yes. That during the first 5 years from the time of diagnosis, there's a higher rate of the disease progressing to multiple myeloma than after the first 5 years. Then the risk goes down. But there is still some risk. And what we've decided after all this time is that the best way to treat multiple myeloma is to use 3 drugs, and I'll talk about those. And we like to see the disease respond as much as possible to get rid of as much of the disease as we can. And we measure that by looking at the serum, protein electrophoresis, the light chains, and the bone marrow biopsy. And as you heard, we consider a stem cell transplant either right at the beginning or when the disease comes back. So the first decision we make, after we decide, okay, this patient needs to be treated, we then have to decide, is he a candidate for a stem cell transplant? And if the patient is not a candidate, you see over there in red, then we could still offer 3 drugs, but there might be circumstances where we would want to offer only 2 drugs if the patient was somewhat frail and we were concerned that they might have side effects from the addition of a 3rd drug. And of course, we would always offer a clinical trial. And then if the patient is a candidate, what we want to do is to give them an induction therapy. That's those letters there, RVD, VCD, IRD, KRD. Those are 3 drug combinations: Revlimid, Velcade, Kyprolis, Cytoxan, and I is for Ninlara. And the important thing then is after we reduce the disease as much as we possibly can with those 3 drugs, then we collect the stem cells. And so in some ways we're doing inside the patient, we're getting rid of the myeloma so that our stem cell harvest has as few contaminant stem cells as possible, myeloma cells as possible. And then you heard how we use the high-dose chemotherapy and the transplant. And then after the transplant, most patients are offered consolidation and maintenance, and I'll have a little bit more detail about that. And, of course, all the things in supportive care, and we'll have a special session just on supportive care, but that means things like anemia, bone disease, infections, a critical part of the care of patients with multiple myeloma. So here is an overwhelming array of ways that we treat patients. And you'll see that for the now, there's those 3 drug combinations that I just talked about. That's the induction. What's sort of new is the introduction of Kyprolis, is one of the more recent things. And what's being studied in clinical trials is adding in a 4th or using 3 drugs with a monoclonal antibody like Darzalex or Implicity. The consolidation, that means, once we've got a really good response with those 3 drugs, we want to try and lock it in some way. And we can do that with a transplant, or we can try using another drug that hadn't been there in the first 3. And after the consolidation, there can be a maintenance. And maintenance is really, we can't really measure anything happening in the patient. There might be a small bit of disease we can measure. There may not be any disease we can measure. So we can't really tell what we're doing by following the blood work or the urine. But we've done studies, and we know that if we do this maintenance therapy, the disease stays away longer. Every single study has shown that. That's the best way to keep the disease away. Not all the studies have shown that patients live longer as a result. But if you put all the studies together and look at it, it appears as though in general, the patients live longer. But I think there's a benefit in keeping the disease away when our therapies are changing so rapidly. If you take maintenance and you keep the disease away longer for an extra 2 years, your options when the disease comes back are going to be better than they would have been 2 years earlier. And so I think at time when therapy changes very rapidly, there's benefit in just keeping the disease away. And then when the disease comes back, that's a relapse, and we have a lot of different options that you can see listed there. And the newer things are the use, again, of the monoclonal antibodies. And HDACs, that's histone deacetylase, and the drug that's approved for use is called Faradac. The PD-PDL1 inhibitors are immune modulators that reactivate the immune system to fight cancer, and there's a bunch of interesting small molecules. And you'll hear about some of these things from Dr. Ken Anderson this afternoon. So what you need to consider is what is the standard of care and what can you expect when you start treatment. And side effects is what you can expect. And so I'm going to talk to you about the side effects. But I think you can also, if you're feeling bad, you can expect to feel better. And then you need to know how we follow the therapy. And I think you heard about that from Dr. Larson. And what are the options for maintenance? And then always consider clinical trials, because I think the standard therapy of tomorrow is the clinical trial of today. And the best way to get the best therapy, I think, is on clinical trials. So I've told you, or I've shown you, a bunch of treatment choices. I haven't told you how to choose between them. That's really a discussion you need to have with your doctor. And I will get into some of the side effects of the drugs. And as a patient, you just want to prepare in a sense that you need to avoid infections, because all patients with multiple myeloma are at risk for infections, and you can do that perhaps by limiting your contact somewhat when you're under treatment. Kidney problems are an issue for patients. They can get dehydrated, particularly in Arizona, and have renal insufficiency. And so it's really important to drink a lot of fluids. And just consult with your doctor. In general, you don't need to make major changes to your normal routine, except when you're undergoing a transplant. But for other things, no. And I'll talk to you about the side effects. You've heard about the side effects of transplant. And there are resources that, if you need to know about them, you can ask your doctor, and you can ask the Arizona Myeloma Network and the Multiple Myeloma Research Foundation to give you some answers about that. So right now, almost everybody, when they're initially diagnosed, gets treated with Revlimid, which is a pill that you take, typically a 25 milligram dose for 3 weeks out of 4. Then when it's given in maintenance, the dose is often 10 milligrams, and it can be given 3 weeks out of 4, or it might be given 4 weeks out of 4 in that setting. It has a risk of blood clots, and so patients can take either an aspirin or an anticoagulant, and I'll give you more details on that. The Revlimid can lower your blood counts, and what you worry about there is your white count getting too low that you can't fight infections. You don't have the white cells. And so your doctor monitors that and will lower the dose if that's appropriate. You may get a rash, which is common at the beginning. It doesn't indicate an allergy. It just means we have to sort of step back and lower the dose and wait, and then we can reintroduce it, and patients are able to tolerate it. A lot of patients complained about fatigue, and there have been questions here about excessive fatigue. And I'm going to let the supportive care people talk about the best way to deal with that. Muscle pain and cramping, diarrhea. And so some patients don't have any of these. Some patients have them a little bit, and we can manage it with lowering the doses. And in some patients, this can be an impediment to using the drug, and we have to find an alternative. And you don't know until you try. The blood clots, if there are risk factors, such as use of high-dose dexamethasone or the use of erythropoietin, Aranesp, Procrit, then we may want to be more aggressive with our management of anticoagulation. And you can see some other risk factors there, which are the same risk factors for anybody having blood clots. And for patients who are at low risk, we just recommend a baby aspirin a day. And for patients that are higher risk, we might use low molecular weight heparin, like Lovenox, or we may use oral anticoagulants like Coumadin, Xarelto, Eliquis, depending on what you and your doctor decide. Velcade is the other common drug used for most patients when they first present with multiple myeloma. It's given as an injection under the skin, typically in the abdomen, and it's given once a week. We used to give it twice a week, but we noted more neuropathy, and we've had quite good results with once a week, but still it may sometimes be given twice a week, depending on the circumstances. The main side effect that we worry about is peripheral neuropathy, and that can be numbness and tingling in the feet, but it doesn't have to be that. It could be numbness and tingling in the hands. Usually it's bilateral. If it's just one foot or it's just one hand, that suggests another cause. But if it's a symmetric thing, then we worry that it's caused by the Revlimid. It can make the platelets go low, and we have to keep an eye on that. Your doctor does. Again, it can have GI upset, fatigue, and rash. So the peripheral neuropathy can be a really debilitating thing, and it can be a reason why patients are no longer able to take this medicine. And it can be painful, certainly tingling and burning and numbness, very irritating. But not everyone gets it, and again, it's something every time you get an injection, typically the nurse will ask you about peripheral neuropathy, and you just have to tell her how things are going, and just keep a very close eye on it with your care team. We reduce the dose, and sometimes we have to use other medicines. There's the use of vitamins or supplements, and then we can sometimes relieve some of the discomfort with the use of Neurontin or gabapentin. So here there's a lot of information, probably more information than you need, but this slide is showing you the different levels of response. At the very top is the most stringent response. That's when we've got rid of the most myeloma that we can possibly measure, and we call that a molecular complete response because we use special next-generation sequencing techniques to look down at how many, out of 1 million molecules, how many myeloma molecules there are. And then as you come down, you get to less response. A complete response, you might still have some disease that we could measure if we used one of the more sensitive techniques above. And then stable disease, and then if you don't respond at all, progressive disease. The disease keeps growing. And this sort of shows you the same thing schematically, although now it's flipped around. The deepest response is at the bottom, and the diagnosis is at the top. And you can see they're a partial response. That means we've got rid of more than half of the tumor. So you can see where the reduction is. And then complete response. And when we get down to less than 1 in 1,000 cells in the bone marrow, we're getting down into the range of the molecular responses. Although there, as I say, we can get down to 1 in 1 million. So maintenance, the most data for that is with the use of Revlimid. And there's 3 large studies. As I said, only one of the 3 showed an improved survival, but if you put them all together, but they all showed, every single study of maintenance shows it keeps the disease away longer. And it's approved for use, and most patients are offered that. And Velcade-based treatments haven't been studied quite as much, but they have shown efficacy, and we tend to recommend them in patients who've got high-risk genetics that you may hear about from Dr. Keats. Ninlaro is being studied in maintenance. It's an oral type of Velcade, and so is Kyprolis. This is clinical studies that have ongoing or just recently completed. These are the kind of things we're studying for the future. And so we're looking at, for patients at high risk in smoldering multiple myeloma, to treat them with 3 drug combinations. You see there Ninlaro, Revlimid, Dex, Kyprolis, Revlimid, Dex. Darzalex is being studied there. Isatuximab is a similar antibody. And if you look into the red column under induction, we're comparing Revlimid and dexamethasone with either Velcade or Kyprolis. And this study's been going on for a few years, and we expect to have the results soon, so we'll know if one is better than the other. Already we know the difference in the side effects, but we don't know if, in terms of efficacy, one is better than the other. In green, if you look at patients who aren't going for transplant, they're looking at Velcade, Melphalan, and prednisone with or without Darzalex. That study has been reported in the New England Journal of Medicine, and it showed that when we added Darzalex up front, so this is a 4-drug combination, those patients, the disease stayed away longer. And there's I think a push to introduce Darzalex into 4-drug combinations, and that presumably will be, say, with Revlimid, Velcade, and dexamethasone, or one of those things you see in orange over there, will presumably be the treatment of the future. And then in maintenance, they're looking at the use of Ninlaro and Kyprolis, and even 2 or 3 drug combinations, just as opposed to just single agents. So when you consider a regimen, you have to say, what are the treatment options for me, and what are you going to follow so that you yourself can keep track of it. And you should always ask if there's a clinical trial that's right for you, because that's where the best therapy is. And we've already talked about banking stem cells. Or banking bone marrow is about whether you can get your bone marrow so that it can be analyzed genetically in a project like COMPASS, and Dr. Keats will talk to you about that. So smoldering multiple myeloma, right now we just recommend that you get monitored closely, and if you've got high risk, consider a clinical trial. And for active myeloma, we'd recommend a 3-drug combination, typically Revlimid, Velcade, and dexamethasone. We recommend an upfront transplant, or certainly a transplant at some point. And we'd recommend maintenance, typically Revlimid. Okay, so now it's time for you guys to do some work. See if you paid attention to what I just finished saying. In general, the best treatment we offer a patient with newly diagnosed multiple myeloma as first-line therapy is induction therapy with 3-drug combination, followed by transplant, followed by maintenance. True or false? Right. So everyone was paying attention. That's good. So I'm going to go over some of the questions here for the that were raised about this topic that I just talked about. One question is neuropathy from Velcade permanent? And the answer is not always. Often it can be bad initially and can get much better over time. And I think you'll hear more about that. But on the other hand, especially when we're first starting treatment, a patient who's going to live for a very long time, we don't want to saddle them with a debilitating neuropathy. And so it's very, very important to keep track of it and to talk with your doctor about it so that we can avoid that happening. And someone asked whether Revlimid causes neuropathy. And in some patients, there's a related drug to Revlimid, thalidomide, which clearly causes neuropathy. And Revlimid in some patients can cause neuropathy. And should a stem cell transplant be considered with smoldering myeloma? Only as part of a clinical trial. So there are patients who've got high risk, and only for high risk. For patients who've got high risk, people are exploring all sorts of different ways of how to treat high-risk smoldering myeloma. These are patients who are likely to progress to active myeloma within a couple of years. And so some are taking a minimalistic approach, just take one pill or or just take an antibody, just something very, very simple to postpone the time till it comes back. And other are taking just the opposite approach, and they're doing everything, every single, 4 drugs and a transplant and maintenance to try and cure it at that stage. And it's a great question for a clinical trial because we don't know what the right answer is. And so that we recommend that if you do have high-risk smoldering multiple myeloma, you see what trials are available for you.